Okay, thanks everybody for coming over. I might need the mic since it seems I have caught a cold on my way here. Anyway, thanks Konstantin for introducing me. It's a pleasure to be here in New York. I used to be in the area for several years while I was at Yale, but for a long time I've been a faculty at Stanford and currently at Ben Gurion University. So it's great to be here once again. So today I will be talking about one of the interesting lines of research that we have been running over the past decade, which concerns mostly automated therapy of patients. And I will also be explaining why, in order to do this, you have to represent two types of knowledge, procedural and declarative, which turns out to be very useful not just for automated therapy, but also for discovering new knowledge, new medical knowledge regarding the same populations, mostly of chronic patients. So this is why it's a sort of a double-edged sword. If you represent clinical knowledge effectively, it can be used both for treatment of individual patients as well as for significantly facilitating the process of the discovery of new medical knowledge. So this is an interesting iterative property of formal representation of clinical knowledge. So, just a few words about where I am currently. The Ben Gurion University Medical Informatics Research Center is currently the main academic center in Israel and one of the top 2 or 3 in Europe. And we have researchers from multiple faculties, mostly engineering and medicine. And our lab is based in the Information Systems Engineering Department, which I used to chair. And I have about 20 graduate students from multiple faculties and sometimes coming from other university, mostly working on medical decision support systems and data mining and similar topics. So, as I was hinting, we have a special interest in management of chronic patients, which are about 80% of the expenditures, even though there are only about 25% of the patients in Western countries. Mostly we focus on tasks such as intelligent monitoring, which means monitoring using clinical knowledge of chronic patients over time, on the interpretation of the data of these patients, on the support to the therapy of these patients, mostly using established clinical guidelines that are presented formally, on the assurance of quality and the assessment of quality retrospectively, again using clinical knowledge and clinical guidelines, on the mining of large clinical data warehouses, in particular over time. You can see there is a clear trend here. We focus on knowledge and on time, and on decision making as applied to individuals seeking therapy using their preferences, and on creation of policies that take into account these utility functions of individuals and of organizations or even countries. Okay, so this is sort of like the main topics that I and my 20 students have been focusing on, and rather similar to what I've been doing at Stanford as well. So let's establish what is it that I mean by saying procedural knowledge. Well, it's mostly the aspect of clinical practice guidelines, which, as you know, are a set of schematic plans, usually decided by a consensus of experts over several years for management of certain types of patients, for example, diabetes type 2, etc. And countless studies have shown that CPGs have a potential to improve medical care by preventing errors, by providing reminders, by creating a uniform level of therapy, and to reduce medical costs by reduction of morbidity, mortality, rehabilitation costs, etc. Unfortunately, clinical practice guidelines are only really effective if they are accessible to clinicians at the point of care and if they're actually applied. So it has become rather evident over the past decade to medical informaticians that you need computer-based techniques to support the automation of guideline-based care in order to actually make these guidelines accessible and to ensure that they are being followed. Now, I would say that there are several different tasks for which we can provide automated support in order to be a bit more specific. First, we could assist in specification and representation of guidelines, which turns out to necessitate a complete methodology. It's not just taking text and writing a program out of it. It's far, far more than that. We need also some validation and verification methodologies to ensure that we have represented the correct knowledge. We need to have search and retrieval facilities to find the guideline that is appropriate to a particular patient and retrieve and then display and browse it. We need to have automated procedures for applicability of a guideline or eligibility of a patient. And then, of course, we need to automatically be able to apply the guideline to a patient or a group of patients effectively over time. And time as a gain of essence, since we believe that in biology and medicine, timing is everything. You really need to have a timestamp, and it changes the way that you look at data when you look at the course of actual longitudinal data. And finally, if we do have standards for therapy and we do have clinical automated records, then we could also perform retrospective quality assessment of the quality of care. So, if I would put it graphically, the overall architecture runs the gamut from individual care by a care provider providing monitoring and therapy, personalized medicine at the point of care, to providing support to a healthcare manager for planning, for research, for quality assessment, for determining policies, etc. Now, how is it done? Well, the abstract architecture includes basically a knowledge base integrated with a database and used by a clinical decision support system to provide both of these types of services. As you can see on the bottom left, we have a medical knowledge library. This is being created by medical experts jointly with medical knowledge engineers. Now, medical knowledge engineers, that's actually a euphemism for graduate and postgraduate students in medical informatics that know how to use knowledge-based systems and can speak not just engineers but medicinese, and actually can represent, together with the clinicians, the appropriate knowledge. But the medical experts and what we call clinical editors are essential, because we have shown, and I will show you a bit of that, that in fact much of the work can be performed by clinicians if you provide them with the right tools without the need for an intermediary, and only the last final formalization can be performed by a clinical knowledge engineer. That has a huge advantage because physicians actually can represent what is it that they want the clinical guideline to do, what are the real objectives, etc. And there is really no programming involved. So having created a medical knowledge library, we integrated at real time with what we see here in number 2, which is the clinical patient record or electronic medical record, in order to provide support at the point of care, as you can see at the top right corner, or if we look at a population of hundreds or thousands or hundreds of thousands of patients, we can also provide services for analysis and policy determination. You also see there a small auxiliary database, and that is because if we actually augment the clinical record with recommendations and with steps of the guideline and with conclusions, we essentially would be extending the clinical record to what I think should be a standard in the 21st century, and that would be all of the intelligent decision support annotations. But currently we do that mostly through an auxiliary database that you could see as a virtual extension of the medical record. So how do we convert guidelines from texts to actual formalized representations that can be applied automatically? Well, there are two problems. First, the knowledge acquisition aspect, which is that expert physicians are great in understanding their domain, but they are not programmers. Second, those knowledge engineers that I mentioned understand very well the semantics of our medical knowledge representation languages, but not necessarily the semantics of the clinical domain. And we have shown that, in fact, a lot of the knowledge in clinical guidelines is tacit and not, or implicit and not explicit, which means that an engineer might actually miss up to 50% of the clinical guidelines content if you only try to represent the written text. So there is obviously a collaboration needed. Second, there is a functional aspect, which is you don't necessarily want to create just a formal representation of the guideline. In fact, the free text representation is also quite useful because you would still like to support tasks performed by humans or humanoids, such as actually searching and retrieving and displaying and browsing guidelines, in which text is very useful. On the other hand, you do want to have a formal representation, a machine comprehensible representation, in order to apply the therapy plan automatically. So you really want to preserve both aspects. So we are down to the question, how are we going to perform the task of converting the huge mass of state-of-the-art clinical practice guidelines into executable representations, while still preserving all of the benefits in the original textual format. In fact, I call this task the Human Clinome Project, as opposed to the Human Genome. And I do believe it's a very achievable task with appropriate resources, and that the technical solutions already exist for performing the Human Clinome Project and for converting current procedural state-of-the-art medical knowledge into a set of machine comprehensible guidelines in a worldwide medical knowledge server. So, having given this uplifting promise, let's look at what is it exactly that we are talking about when I say a knowledge base for medical knowledge. Well, one option is to use a resource that we have developed, which is the Digital Electronic Guideline Library, which in fact implements an incremental and collaborative process that performs exactly what I've described, namely a collaboration between medical experts, clinical knowledge editors, which are typically, say, fellows, residents, interns, who are not necessarily experts in a particular clinical domain, but understand medical language and understand our tools. And knowledge engineers, which, as I say, are mostly coming from computer science, medical informatics, biomedical sciences, etc., and understand more about the technology. The result is a hybrid representation of the clinical procedural knowledge that has several levels, from the full text to a completely formal text, including also a semi-structured format that has text segments with labels such as eligibility conditions, abort conditions, expected outcomes. A semi-formal representation level that includes control information such as these 2 medications have to be given concurrently, or these 3 actions have to be done sequentially. And up to the formal representation, which is completely machine executable. This implies tools for uploading guidelines, for indexing them, for marking them up into segments of text that have semantic labels such as eligibility conditions or objectives, and for providing for search and retrieval of guidelines. And we even have an authorization role, since once you get to the practical details of creating such a library, there is the obvious question: who is authorized to actually edit important clinical knowledge that is going to be applied to real patients? And there are multiple aspects of this that I will not discuss, but that you can imagine, and for which we published several solutions. So to give you an overview of what would be the life cycle of a clinical guideline that is published by, say, the American Association for Diabetes and is being converted into formal knowledge. So it's a collaboration between the senior medical experts who actually have to form a consensus regarding the core of the guideline. Then clinical knowledge editors who actually perform the semi-structuring and the semi-formal markup of the text guidelines into increasingly formal representations. And finally, knowledge engineers who perform the final formal structuring. And we actually have different representation formats for each of the process phases. But we maintain, as you can see, throughout the process, we maintain all of the formats. So the guideline library actually includes the free text, the semi-structured representation, the semi-formal level, and the formal representation. And each of them is used for different purposes. Okay. No, when we get to this point. Okay. So, let me show you an example of one of the tools that is found to be very useful by the medical experts and clinical editors. It's called the DeGeL Guideline Structuring and Maintenance Tool. And what we see on the right is a clinical editor who is marking up some text, and she's choosing a particular label on the left from the guideline ontology, from the guideline representation structure, which means that this particular text segment is going to be structured and saved under that label, for example, eligibility conditions or the body of the plan. On the left-hand side, we have an example of actually creating the procedural knowledge that follows the guidelines workflow. For example, in this case, determining if this is a severe preeclampsia toxemia situation, given criteria that eventually are going to be formalized and automatically computed. And then actually moving into subplan A or B, dependent on the result of the decision. As you can see on the left-hand side, as this is being drawn by the clinical editor, a plan is being formed that can be explored and annotated, and it's actually represented in XML. So this was the procedural knowledge of the workflow. But I also mentioned a second type of knowledge, declarative knowledge, because we don't want to just say if then else and do 3 times. There are also clinical concepts involved that might include pretty complex patterns, such as deteriorating renal functions or mild preeclampsia. These concepts are actually a function of existing time-stamped entities in the patient record, such as high blood pressure or protein in the urine. And what you see here is the Gesher tool being used to create a declarative knowledge map that includes medical concepts, most of which already exist in the declarative knowledge library, and creating the new concept of mild preeclampsia. So these links actually are functional links that mean that the top level notion, concept, is abstracted from all the rest. And you can also see from the semi-structured representation of the guideline a piece of text that annotates the concept of proteinuria. And finally, you can see constraints on the concept values that have been added by the clinical editor and sometimes by the knowledge engineer. So in fact, since the low-level concepts are mapped into standardized terms, in this case in the Unified Medical Language System developed by the National Library of Medicine, it means that this knowledge map actually can be applied to any clinical database once you associate it with the low-level data concepts in that database, and then can actually be used to compute all the high-level abstractions that support application of the guideline. By the way, such a map can also be used to represent a complex temporal pattern of behavior over time. It's again a type of declarative knowledge. This is an example of another tool we have been using called Uruz. Oh, by the way, these strange names, I have to apologize. Our rule is if you build it, you can name it. So if a doctoral student builds a tool, they are allowed to name it as they wish. So Uruz actually comes from the Nordic mythology. So this is actually a web-based tool that has often been used by our clinical collaborators in order to structure a guideline. Again, you see a piece of text being marked up and saved under the plan body. And here you see part of the actual structure of the plan. This is the web-based plan body wizard that allows you to create plans that run in parallel, in sequence, or periodically. So 3 dots means sequential, and this circle means periodic. These 3 lines mean parallel, etc. You can search through the guideline library using tools such as a tool called Viduria, about which we published various papers and asked for guidelines following various semantic criteria and indexed under various semantic indices. And you can also search for text in the guideline that appears only within a particular semantic label, such as treatment of diabetes patients with hypertension must appear within the eligibility conditions. So that's a different kind of a search criteria. And we have shown that it actually can considerably improve the precision of retrieving guidelines, even if you use a standard resource such as the National Guideline Clearinghouse of the NIH. Okay, so we have a knowledge library. We have tools. One of the questions that might come to mind is, can clinicians actually use such tools to create high-quality guidelines that can be applied to real patients? We actually thought about this quite a lot, and in the case of the URUS tool, we performed a 4-year evaluation with generous assistance of our colleagues from Stanford and from Ben-Gurion medical centers, for which we created a 9-step methodology that starts with a consensus about the clinical guidelines semantics and ends with a formalized representation that can actually be run. This is actually a very general methodology. It can be applied to any guideline methodology, such as those developed by some of my colleagues at, say, Columbia or Harvard. It's a general methodology because it says how are you going to perform such an evaluation exactly. In particular, you go through a consensus, you go through actual structuring of the guideline, and then you evaluate the result of the structuring using syntactic and semantic criteria that have been predefined. For example, is this formalized correctly according to the guideline language's syntax, and are the semantics still the same as originally intended in the original clinical guideline in the text? Of course, this evaluation is done by other experts that are not involved in the structuring. So the results were that with respect to completeness, namely, did all the elements of the guideline actually appear after all these 9 steps in the final formalized result? Well, yes, more than 90%, actually 97% of the plans, and 91% of the knowledge roles like eligibility and abort conditions and intentions. As to soundness, which was whatever was represented actually correct, well, we had a mathematical correctness concept that I will not explicitly define here, but which is pretty intuitive. But it turned out that although the correctness is certainly significantly higher than random segmentation of the guideline, and much more also than randomly assigning scores from -1 to +1, it actually was pretty good, usually from 60 to 90%. It really depended on the knowledge engineers. There were some, and on the clinical editors. But those who actually had 90% accuracy usually were accurate across all guidelines. So this emphasizes that given an appropriate set of tools, you can actually take a set of guidelines. We did it in 3 different domains and convert them into a formalized representation that can actually be applied to patients. But it means that with respect to the soundness, the accuracy, you probably want to take those editors and knowledge engineers that have passed all of the training in order to ensure the correctness of the final result. But it's definitely doable. Which is why we think that the human plenum project is actually quite feasible, especially if you perform this concurrently on something like the 5,000 main guidelines that we estimate exist in the world. By the way, what is written there in small text is that we actually did additional studies showing that human editors, when asked whether they understand the semantics of the underlying ontology, the knowledge structure of the guideline, give you pretty frank responses, which have a pretty good correlation to the ease that they report when actually doing the structuring. Unfortunately, they do not necessarily have a high correlation with the quality of the knowledge that they produce. In other words, a professor of medicine might say, I absolutely understand what it means to have an eligibility condition in your language, and nevertheless, the resulting expression that he creates might only have 80% correctness, while someone who says, I think I understand it, might have 99% correctness. Our conclusion was that if we want to have a large-scale operation of this type, we need to have training courses for clinical editors to make this quality of representation be uniform. But as far as we know, this is the only study that has been actually carried out with real guidelines and real physicians to create real representations, as opposed to theoretical experiments. It took 4 years, but we now know exactly what can be done. Okay, so that was as far as it goes for procedural knowledge. Now, I mentioned declarative knowledge, which is the knowledge map and concepts and temporal patterns and definitions. In fact, this is a crucial part of medical knowledge. So, for example, in monitoring and diagnosis, we might search for a gradual decrease of, or decrease or increase of fasting blood glucose, but we have to define what do we mean by gradual increase. Does 0.1 of gram per deciliter count as an increase? Is it beyond the statistical tolerance of the lab measurements, etc.? Similarly, if you follow a clinical guideline to treat a patient, there are many, many concepts within the guideline that are in fact implicit medical knowledge that have to be explicitly defined. Same for quality assessment retrospectively. And of course, if we want to perform research and detect hidden dependencies and correlations over time between, say, pre-existing states, certain medications, and effects within 6 months to 2 years, these are very interesting patterns, but they are composed of clinical concepts that are themselves often a whole tree of a functional tree derived from low-level concepts that are in the clinical record, that are lab results, that are signs and symptoms, etc. So there is a lot of declarative knowledge that we need to represent. And the good news is that once we represent it, we can build on that knowledge to create additional knowledge at a relatively low cost. Now, another reason for explicitly representing this knowledge is that we really need an intelligent mediator. What I mean by this is that clinical databases currently store only raw timestamp data, such as 7.8 gram per deciliter hemoglobin on 9:31 a.m. of a particular date. But when we reason about patients, we reason in terms of abstract patterns and concepts, such as liver dysfunction or bone marrow toxicity grade 2. So we need a mediator between our needs for therapy, clinical research, policy determination, and the low-level concepts that are currently in our electronic medical records. One such architecture that we are doing a lot of research about, starting at Stanford University and then at Ben Gurion, is the IDAN temporal mediation architecture, which enables one to access heterogeneous time-oriented clinical data sources and supports querying both about the raw data and very high-level abstractions, sometimes at the 5th, 6th, 7th level. And essentially it allows one to combine clinical data sources, which are time-stamped and raw, with clinical knowledge sources, which actually represent the abstract concepts and patterns. And it supports applications such as NAVE2, which I will show you soon, for interactive visual exploration of the data in terms of the high-level concepts, as well as the guideline application tools such as a system that we call Spock. So here is a sort of an abstract view of EDAN in action. What we see here is a clinical user. In this case, she's using NAVE2, which is our visual explorer. The query actually passes through a temporal abstraction controller, which consults with the knowledge service. It's a web service that actually includes the knowledge base, and if you ask about, say, bone marrow toxicity, myelotoxicity, it says, yes, I know about such a concept, but it's composed of, say, platelets and granulocytes, and you have to extract them from the data. So the controller sends a query to the data access service, which is another web-based service, and says, I need the platelets and granulocytes of this patient. And by the way, the knowledge service tells me I also need to know about the date of the bone marrow transplantation or transplantations. All of this, by the way, is using standard medical vocabulary, since it has to use international standards. Once the data comes in, it's transferred to a temporal abstraction service that actually performs the computation of the relevant patterns, returns them to the controller, which returns them to the application. In this case, it's the visualizer NAVE2. The knowledge base, meanwhile, is being maintained by our knowledge acquisition tools, as you have previously seen. So this is a typical application. You can see on the left-hand side what we call the ontology of the domain. This happens to be oncology. And we have concepts at the lowest level and also at higher levels that are defined from the low levels. And on the right-hand side, we see that the expert has opened several panels by clicking on these concepts, such as the white blood cells and the platelets. But we also see abstractions being computed from them, such as 3 weeks in July of very low white blood cell state, platelet states, and we see a high-level pattern being discovered here of myelotoxicity grade 3 for more than 3 weeks for this patient. And by the way, if some of you see a hazy shade at the edges of this pattern, it's not because your eyes are becoming weaker as my talk progresses. It's because there is actually probabilistic decay in belief in some of these concepts in areas where some data were missing, but they nevertheless exist. I will give you an example. If I just measure your hemoglobin, I discover you have mild anemia. That's great, but it doesn't mean that it has just started. It must have existed for a few days before I measured it, and will continue to exist for several days at least, depending on the context, after I measured it. So if I'm not megalomaniac, I have to conclude that it's not because I measured your hemoglobin that anemia was created, unlike some modern interpretations of nuclear physics, but that in fact it already existed and I just measured it. So it means that I can interpolate using the half-life of hemoglobin between different measurements of hemoglobin to decide first that you actually had anemia throughout the month, and second, that it probably started before I measured it, although I am not quite sure when, and that it continued beyond the period for which I have evidence, although I'm not absolutely sure to which point, but it can be given a statistical formulation. So That's what we mean by this fuzziness in our concepts. And this is a very helpful concept because it enables us to summarize very succinctly huge amounts of data using their internal properties, because in real life we're not measuring data every second. Okay. You would be surprised, by the way, how many physicians are convinced that anemia or any other problem for that matter has started only when they measured it and not a second too early. But this is not the case, we believe, in real life. Okay. We actually performed an evaluation of this tool as well to see if physicians can use it in order to manage their patients, in this case in the oncology domain. This actually happened with the generous help of the NIH and the VA healthcare system in Palo Alto over about 3 or 4 years. And we used about 14 clinicians and about 1,000 patients. And we used 10 questions that came from the protocol by which these patients were actually managed. It was a post-bone marrow transplantation protocol. We did it as a crossover study because we compared the NAVE2 application with paper charts and with an electronic spreadsheet, which was used as the EMR at that point. What we measured was how long it took to answer when given a particular question in the protocol that you're supposed to answer during a clinical visit, and how accurate you were. And we also used usability scores, because it's very important to have a tool that is not just functional but also usable from the human-computer interface point of view. Well, the results were actually very encouraging. They were published by my colleagues in the Healthcare Technology Assessment Center of Stanford. And NAVE2 was always ranked first in preference over paper and EMR. In particular, we used something called the Standard Usability Scale. As you could expect, users were significantly faster using this tool. All you have to do is to click on a concept and you can see the chart, and then you can, by the way, let me point out that if you clicked on July, you would zoom into July 1st to July 31st, and you can continue to zoom up to the level of seconds. Or you can zoom up by clicking on the lower level, 1995, to a decade. So you can look at decades of data or seconds of data depending on the domain, and you can zoom very quickly in and out, and you can see the abstractions at all temporal granularities. That is very important because certain very interesting interactive insights were gained by the clinicians by looking only at the level of months, for example. With respect to correctness, well, with respect to time, obviously, you can do in seconds what can be done in minutes, but this was now proven formally. I was surprised, by the way, that some of the questions took the clinicians more than 15 minutes to compute. Since they only have at Stanford about 7 to 10 minutes per patient, I would find it hard to believe that they can answer 10 such questions in one visit, and therefore have to conclude that either they have some ESP ability to glean the answers by just looking at the patient, or that they are guessing. In fact, this seemed to be the case when we looked at the correctness. Physicians would just use the electronic medical record without any intelligent decision support capability, but actually having all of the data in their eligible at their fingertips, answered the questions by the protocol with an accuracy of 57%. But using NAVE2, 92%. So you can see where the p less than 10 to the minus 4 comes from. So our conclusion is that if you actually need to treat a patient and to really follow a protocol with all of these complex questions that have been put in by senior oncologists, other than using these computerized means, I really do not see how you can do it in the 21st century. The final question is, what happens with populations? Because we also want to support research on large-scale patient data warehouses. Well, we have extended the concept of naive to a concept we call visitors, which actually looks at multiple patient records and uses, again, knowledge-based interpretations. So we are exploring not just the raw data, but many higher level concepts, displaying interactively and interacting with the data, and performing association and aggregation over multiple records. And again, we evaluated it for functionality and usability. So here comes the visitors display. This actually was, although it might seem daunting, was actually pretty clear to the clinicians who already have used naive 2, because, again, you can see on the left-hand side a knowledge browser for the clinical concepts of the domain, sometimes very high-level concepts. You can see a search interface where you can just enter a string and search for a concept in the patient's record or over a whole population. And here you can see the data. So this is the data, in this case, taken from about 1,000 patients, 58 of which answered some criteria that were entered by the clinician. And you can see the data over time, and what we plot is usually the minimum and maximum. The maximum values are in red. Minimum is in blue. If you click on a particular outlier patient, you will open the patient's record in this tool, and you will be able to explore that outlier very thoroughly. If you continue to look at the whole population, you can see distributions of abstractions over time. So for example, here we see the distribution in April of the state of white blood cells from very low to very high, and we can see where most patients were. Similarly for the hemoglobin state, and we can see that suddenly in October something happened and the distribution is very different. Actually what we see here is the temporal pattern of the distribution. We can see how the distributions are changing. And let me point out that it doesn't have to be absolute time. It can also be the first, second, third month after delivery, the first, second, third week after bone marrow transplantation, initiation of chemotherapy, and anything else that is entered in a special field called reference time, and that comes from the knowledge base. And actually using this comparison across relative time proved to be a very effective research tool. For example, you can compare the distribution of how the bone marrow rejuvenates itself after bone marrow transplantation, and it's immediately apparent that it's very different for different types of transplantations, such as allogenic and autogenic and so on. So this is actually a very powerful research tool, and again I remind you that it's based on patterns that have been pre-computed by the Mediator. You can also ask other questions such as what is the association over time among different concepts? For example, between the platelet state and the hemoglobin state, where the state is in abstract terms defined in the context of bone marrow transplantation using context-sensitive tables. So what we see here is a tool we call Temporal Association charts, and we actually associate different patterns over time. For example, here platelet state and white and hemoglobin state. Now, we use here a semantics of association rules in data mining, so that the broader the line, it means that there is a higher support. In other words, a larger population that actually had moderately low platelet state and normal hemoglobin. And in fact, the support here is something like 54%. Another measure that you can immediately see is that the deeper the red shade, the stronger the confidence. In other words, if you ask, what is the probability that if you had moderately low platelets, you would move into normal
hemoglobin state by the end of the month. This is given by what we call confidence, and that's, in this case, 92.6%. So you can actually see here that you can see immediately temporal patterns in, say, diabetes patients over the first 7 years of therapy, and realize that, in fact, there are 6 types of patients because they have different temporal clusters. But again, we are using the same knowledge already being defined in the knowledge map for therapy, but we are now using it for clinical monitoring, research, policy determination, and much more. Here you can see, just for example, that we included a few data types that are completely raw, and here each line represents a single patient. While here the line represents, of course, the whole group of patients. And you can see that most patients seem to actually converge into the normal hemoglobin state, but then split into different liver function states according to alkaline phosphatase. This is an interactive tool and needs to be played with to be completely appreciated. Seems to have endless possibilities that we have not completely explored it. I said that we actually are applying the clinical guidelines at the point of care. So we have just seen how we represent procedural knowledge and declarative knowledge and how we explore them, how we acquire them. When we apply them, we have to apply both of them, because to treat a real patient, you need to both interpret the patient's state over time to determine the status of the patient and to determine which part of the guideline is applicable. This is being done by a tool that we call Spock, and it has a modern tool that we are currently developing called Picard. To those of you who are trackers, I need to provide no explanations. But Picard and Spock, well, Mr. Spock actually was called this way because he's a slightly annoying tool. It's annoying because he's always right, but he reminds you of important facets of the guideline that you might have overlooked, such as this is a pregnant woman and she had a high blood glucose. Surely, doctor, you want to send her to have her take a glucose tolerance test? And you say, oh yeah, sure, that I was just going to put that. So Spock is like this human with, or semi-human with infinite wisdom, but he's not necessarily above the physician, because we think that to be modest and realistic, we never really know everything about the patient that the clinician working with her knows. So we can only provide recommendations according to what we know, which is through a very narrow channel of information to the database. So, to be realistic, we are just assistants, but intelligent assistants. So this was also evaluated in several domains. Let me just point out that there are several modes of applying clinical guidelines. It really depends on whether you have an available electronic patient record or not, and whether you have a completely formal machine executable guideline or you're still in the semi-formal or even semi-structured text. We can actually support both formal and semi-formal representations, and we can even work with semi-formal representations when an electronic patient record does not exist, because what we do is we use the clinician as the mediator. We actually say, does the patient have, say, known atrial fibrillation, as in one of our applications for congestive heart failure? And we don't look that up in the record if the record does not exist. We actually ask the clinician, but we can still provide perfectly good decision support. Of course, the best situation is the top left corner, which is an electronic patient record is available and the guideline is formal, but you can see how it would be useful, and it is, even when an EPR is not available. But in that case, we actually use the semi-formal representation, which is another good reason that we have luckily saved it in our library and not just the formal executable representation. So overall, the architecture that I've shown to you earlier as a very abstract one is actually materialized as follows. Here you see the Digital Guideline Library server. Here you see the IDAN temporal mediator server that has the patient's data and a knowledge-based level of abstraction above it. And the Spock engine actually integrates both the guideline and the interpretation of patient's data to interact with a user and provide recommendations while also maintaining an application log of all the recommendations and justifications, and from time to time calling the nav2 application to visualize the patient's data when necessary. For example, for explanation purposes. This is supposed to be a movie. Do we have 3 minutes for that one? So, let me just explain what is in the movie in case we will be able to see it. This is a project we are doing with a large HMO that has a call center for telemedicine of chronic heart failure patients, especially those treated using warfarin and diuretics. So the patients actually have a system at home that broadcasts their pulse rate, blood pressure, and weight several times a day.
Anticoagulants or the specialized team of nurses at the call center. The application utilizes telemedicine data and the patient's individual data in order to assist the nurses to flow through the guideline. Now let us take a look at the application. In the demo of our application, you will see the nurse's dashboard. All of the data here is live, which we received from the local health maintenance organization. As you can see on the upper right-hand corner, the patient is stabilized as he is within the INR target level. We will now show you that all of the data here is actually live and see the INR, coumadine, and telemedicine data. We will now be adding the new patient in order to demonstrate to the system. Once the new patient is added, the protocol starts to work. As you can see, we don't have a target INR level because we are missing an important piece of data. Once the INR data is added, we can see that this patient is within the INR target level and therefore is colorized as green. If we add a mechanical valve, then you would be out of the target level and therefore would become blue. Back again to the green level. We will now start the consulting session. The consulting session is for the specialized nurse and takes the nurse through the actual protocol. We also have the ability to show conversation summaries. In the conversation summary, we ask the patient important data, in this case, getting the actual coumadine dosage. We also ask about bleeding in order to check for vital signs. Once we have the important data, we again repeat the question for checking the INR value, and dependent on the answer, the protocol will give us what is the new coumadine prescription level. In this case, we're able to decrease it by 50%, and the protocol will tell the nurse to schedule a call in another 2 days. We can also show the actual clinical workflow in a separate window. This window will show the current clinical pathway, and you can see what is going on behind the scenes. We computerize all of the 36 clinical pathways in this guideline. In the next step, we will show how the guideline deals with the worsening condition of the patient. The application, of course, knows that to deal with the different protocols. In this case, the origin of the patient. The application, of course, knows that to deal with the different protocols. In this case, the origin. It shows the nurse that she has to look at this particular patient with updated INR data. It shows the patient is outside of the target level. Changes his status to blue, which means, of course, a different clinical protocol. The conversation summary that is popped up, again, provides the input for the current medical data. step-by-step step, which ensures, of course, that the nurse does not miss any of the necessary steps, thereby preventing errors of omission. You can see here that we keep all of the conversation summary data stored, though it is in free text. The next part of the system that we will show you is how we take raw medical data, which is shown here in the medicine box, and show it graphically in order to lower the cognitive load on the attending clinicians. In this case, our graphs are easy to understand, visual tools that can in and out from seconds into years, and as the raw medical data is popped up, we have the ability in our knowledge base to convert the raw medical data to the relevant medical concept. In this case, healthy patients according to their defined state. And this here we show that and for how long the individual patient was at the correct defined state. And we also have a multiple patients graph. Here we show the entire CHF population graphed according to their blood pressure and BMI state, showing the attending clinicians exactly how many of their patients were in a particular state. In this case, one over here, 2 out of 4 patients were overweight for a particular period of time. This, of course, allows the clinician to get a much better intuitive view of their.
Okay, so okay, great. Thanks. So this was basically just a short demonstration of a working application. In this case, it's a call center. And as you could see from the narrator's text, it's actually the nurses are using this system because in that particular call center, in order to considerably cut down on expenses, specially trained nurses are calling patients or patients are calling in. So there are several ways of initiating the dialogue, and the decision support system needs to be prepared for all of them. And the nurse is actually qualified to modify the dose of medications such as warfarin, but not start any new ones. If there is a need according to the protocol to start something new, there is actually a cardiologist 24/7 available to confirm permission. But 95% of the cases actually can be handled by the computer system and the nurse. It means that if the patients are calling from their homes, having sent their telemedicine data over a wireless connection, and do not really need to come to the clinic unless the protocol indicates that they should. So that's a typical application. In this case, actually, not in a hospital environment or ambulatory clinic. It's actually a telemedicine service. Okay, the last point I want to make on our list of tasks that I promised to support at the beginning of the talk is quality assessment. So, assuming that we have, as I hope I've persuaded you by now, a methodology for representing the details as well as the higher level goals of clinical guidelines over time, according to some standard state-of-the-art clinical curve. And we have a capability to analyze data over time using these concepts. What we can perform is a guideline matching task, which says essentially that we can determine to what level did a clinician adhere when applying a particular guideline over time to a set of patients. fact, we can do more than that, because since we have a library of guidelines, we can say, it looks like you are trying to implement GNC 7, but there are some deviations from this that you might want to consider, which you might be doing on purpose, or maybe you are not. This is called the plan recognition task. It's a very interesting task in artificial intelligence that I've been working on for a long time. And essentially, we're looking over the shoulder of the physician and using all of our temporal reasoning and planning knowledge to determine what is it that she's trying to do and help her. So you could either suggest how to proceed in the correct application of the guideline, or if you just have a database or a data warehouse, you could try to identify which guideline was probably being used. And this means that you're looking at the guideline that is nearest according to some distance function to the actual execution trace. And then you can use this as part of research. For example, you could automatically determine which guidelines were probably used in a large longitudinal retrospective database. And you could actually compute what were the results of applying them and which work and which do not work. So you might ask, why do you need to compute this? Can't you just ask the physician? But you probably know as well as I do that clinicians never actually record in the database of the patient which guideline are they following. They are simply following it if they are. And even if they do follow a guideline, they do not necessarily adhere to all parts of it, perhaps for a good reason. There's also the interesting question of a non-deterministic matching, because suppose the guideline says you have to start treating the systolic blood pressure if it's over 140 or the diastolic blood pressure is over 90. Well, what if it was 91 and nothing was done? How bad is it? Well, not as bad as if it was diastolic 98 and nothing was done, right? So you need to have some some non-deterministic measure of partial match to say how significant was the deviation. So the output really has to be a continuous degree of fit between a clinical longitudinal record and a particular guideline, and a real justification for that, because physicians are going to ask, why didn't I get 100? Why only 89? What is it that was different? And exactly why is it important? So we have done quite a bit of research on that at Stanford and Ben-Gurion, and it turns out that using exactly the same knowledge we have already represented, but adding to each feature an importance measure, which really is a utility function, specifying explicitly how to abstract it from the data, and adding a fuzzy membership function. For example, you want to maintain the blood pressure between, say, systolic 70 and 140. How bad is 143? So that actually can be solved by something called fuzzy logic, and in this particular case, it turns out to have semantics that are very useful, as opposed to the usual probabilistic syntax and semantics that we use in other applications, because we're not talking about the probability that something happened, but more like what is the degree of membership of a patient who has systolic blood pressure 143 in the group of patients who have high blood pressure, which is really a slightly different question. So we can do this automatically for each record and for each guideline. And then we can say a lot of things, such as if one guideline seems to be really similar to what the physician is doing, we may conclude that she's trying to follow this guideline. If no guideline seems to be closed, then either she's using a guideline we don't know about, or she might have very good reasons to reject all guidelines. And when we give the score, obviously, each facet of the guideline needs to be given a different utility, because it might be much more important to use a beta blocker instead of an ACE inhibitor, but not so important to, say, measure the blood pressure 3 times a day as opposed to 2. We actually evaluated this on a real database taken from a large HMO, including about 700 patient records, of which about 500 included the drug therapy data we needed. We used about 50 of them randomly for comparison with the expert, but we actually analyzed all records. We also took 2 well-known guidelines, JNC 6 and its more recent adaptation, JNC 7, which are antihypertensive, and 16 medical centers in Israel actually were part of this. And we asked the expert, he's an expert on antihypertensive care, to give us a score between 0 and 100 for each patient record with respect to similarity to the guidelines that were used. And we always used the similarity with the guideline that seemed closest, which was JNC 6, JNC 7, or none of the above. And the results were actually quite surprising to me. There was a really very good match between the scores provided by the system and the clinical expert scores. I was surprised. I wouldn't be surprised at all if we gave a score of 70 when he provides a score of 49, as long as at least we have some linear correlation. But actually, it was literally the same scores. But let me caution by saying that it does show the usefulness of fuzzy temporal pattern matching for quality assessment, but it was only for this particular expert. So what we can do is we can mimic, using our algorithms, the judgment of one single top-level expert. I'm sure that another expert would give different results. But the implication is that if, say, an organization has a board that determines a particular set of criteria, we can mimic those criteria and compute them for 1 million patients just as easily as we do it for one, and get a pretty good match with their manual scores. Okay, so to summarize, I've talked today about one of several lines of our research, which is medical decision support systems, and especially for guideline-based care. And I've shown that if you look into this task in depth, you need to represent both procedural and declarative knowledge, and it has to be about time and about clinical knowledge at several levels of abstraction. We can actually support automated guideline application at the point of care, maybe even at the patient's home, as you have seen in the movie. I've talked a little about the Digital Guideline Library, about the done temporal mediator, and about the NAVE2 application for exploration of individual patient records, and the visitors application for supporting research that explores large patient populations and temporal associations amongst concepts, etc. We use the results a lot also for other projects involving temporal data mining. Those of you interested in that can come to me later and ask about this. And as I said, I think it's quite feasible to start a sort of, if you want, a global venture here in the 21st century of the Human Clinome Project, where we represent as much as possible of the world's standard of care of procedural knowledge, namely clinical guidelines, and make them available for immediate download and application on any electronic medical record, just like is in the Matrix. This is actually today, it's not tomorrow. It requires just resolve. So, I would like to really acknowledge here the support of the NIH and many of my colleagues at Stanford, and in Israel, and you're welcome to come and download some of our movies. Thank you. Any questions?
Some of the tools you presented are absolutely phenomenal. I think that applying them, for example, here at this medical center would be incredibly useful. How easy it is? What kind of what are the milestones for working this technology and making it work here?
Okay. That's a good question. In fact, in order to, since there was such an interest internationally in some of the results here, Ben Gurion University has recently created a company called Mediator that incorporated all of this code and maintains it so that academic institutions and HMOs and medical centers can actually create their own systems and continue to build on them. And it's not just the systems, it's also the underlying tools for knowledge engineering, which have all been developed with a look to the future to enable extension and to be compatible with each other. So there is a whole suite of tools, and it is being maintained by this subsidiary in collaboration with my Medical Informatics Research Center. And we certainly encourage institutions to start creating their part of the Human Cleanup project. Yes. Yes.
So in terms of generating a guideline, so if I was an institution, I had a guideline that I developed, and I wanted to implement it and formalize it. Can you give me some estimates on what are the resources that I need? So I need at least 2 people, right? I need an expert. So give me a summary of some of the resources I need and who I have to hire to make this happen.
Excellent question. In fact, this is what we try to answer in this work. It was published in JBI. It turns out that you want 3 types of people. You want a senior medical domain expert who really understands, for example, hyperthyroidism. Then you want to have a clinical editor. Fortunately, our research has shown that this could well be an internist. It could be an intern, it could be a resident, a fellow, as long as they have had some 2 or 3 weeks training in our tools. They don't have to be domain experts. The domain experts are necessary in order to create a consensus. And you will be surprised, by the way, how often that consensus is different from the published guideline. At Stanford, it took us 2 weeks of arguments to determine who are the chronic obstructive lung disease patients, even though that's the first sentence of the COPD guideline from the NIH. But it turned out that each of the senior physicians at Stanford had their own view. Once you create such a consensus, and we have a tool to support that, then the clinical editor actually structures the guideline using our tools, and the knowledge engineer, which is the third part of the staff, actually formalizes the last step if needed. These are the 3 roles that you need: the medical domain expert, the clinical editor, and the knowledge engineer. Then you need a database engineer that links the knowledge base to the local database. That, for example, knows that hemoglobin is actually LOINC 731.2 and can be linked, say, at NYU Medical Center to an entity in the database called automated hemoglobin. Once that handshake exists, you can actually apply any guideline that uses these concepts, including the one that you started with. And this is more or less the path that we have followed in most of them. Yes?
How variable is that handshake you just described? The different electronic medical records and formats?
Okay, good question. Well, there is a reason why we insist on maintaining the knowledge base only in international coding standards, and that is because there are so many different parameters. For example, your underlying system might be using EPIC, or it might be your VA system, which is using something that was very cool in 1964 but no longer is, or any other homegrown system. But because the knowledge base only uses international standards and units, you can actually create a lookup table that says whenever someone asks about Loing 732, they actually mean hemoglobin 1 from lab data. And from that point on, you have made the handshake. Which means that you never have to actually change the guideline, because it's using international standards. You might have to change the lookup table when you replace your database. Yes.
I have one more question. So the example you showed earlier with preeclampsia, and you showed high blood pressure, and you showed the procreate. So does the guideline, so the guideline gets applied automatically, right?
Yes.
And it goes to the record. Do all three of those things, I think there are three or maybe four, have to be present to get the diagnosis? Because let's say you don't have a lab, you can't measure the blood pressure.
Okay.
And all you see is high blood pressure, and they're 20 weeks or 36 weeks out, they have high blood pressure. Is it going to be tripped, and then you start going down the guideline path, or do you have to explicitly tell them?
That's a good question. So this is why I was showing that there are several different modes of application. Suppose that some of the lab data are not actually in any electronic record. This would be the case of an EPR being unavailable. Fortunately, the library of knowledge also includes a semi-formal representation of the guideline where you can actually issue a text question saying, does the patient have an abnormal glucose tolerance test? Is alkaline phosphatase higher than a certain level? And the physician will say yes or no. In fact, this is what happened with the nurses in the movie. And for certain types of interactions, such as are you smoking or not, that might not exist in the EMR, the nurse was actually entering the data. And we proceed with the guideline as if the data came from the EMR. In fact, you can run the whole guideline without an EMR at all when an EPR is unavailable, just using the semi-formal representation, which already has all the control knowledge to perform a complete simulation of the guideline and support care. We would like everything, obviously, to be using the underlying EMR, but we believe that a realistic implementation will always have to cater for certain types of data that are never going to be in the EMR. Let me give you an example. For example, when we worked with the Opgene department, we found out that to use one of the guidelines they really wanted us to implement for pelvic inflammatory disease. One of the questions that you need to ask the patient is the number of sexual encounters she usually has per week. It's not a question whose answer I would expect to find in the EMR. So obviously, there is always going to be a semi-formal element in every interaction. On the other hand, if data exists formally, you can do a lot of things under the hood that make decisions much faster. Let me also point out, since you mentioned the preeclampsia example, that this is a good way of introducing why exactly we need temporal reasoning. In the guideline published by the NIH, it says that part of the symptoms and signs include diastolic hypertension and proteinuria. But do they have to occur on the same day? How about 2 days apart? How about 2 months apart? So, where is that written? Well, that's an example of implicit knowledge that you actually have to represent as part of your knowledge acquisition process. And by the way, when we asked 3 different senior physicians, we got 3 different answers. So obviously some of the guideline applications are not going to be the same. When proteinuria was detected 2 weeks before the high blood pressure, depending on the clinician and depending on the medical center, which is not what you want. So one of the multiple benefits of formalizing knowledge in this human clinome project is that guideline application really becomes uniform, because using the half-life of the temporal predicate, proteinuria, and systolic and diastolic blood pressure, you make sure that only when they intersect, you actually had both existing. And that's what you really mean by encountering both of them. And I think that actually the process that we went through in this case with our Stanford and Ben Gurion colleagues was very useful, because even if you disregard the automation of therapy, the fact that the knowledge has become formalized and uniform for these guidelines is valuable by itself.
Sorry, I wanted to clarify. What I meant is, what if you have missing data? So you don't know if they have proteinuria, and because you just don't have the capability.
Right.
So then what happens?
Well, in the case of missing data, it's exactly as in the case of the sexual encounters. You actually ask, did your patient have proteinuria? Because it might not have been introduced into the database, but the clinician might know about it. As in the case of, is she a smoker? Okay. If you have no data, then often you will be able to bridge over a gap in the data using the temporal interpolation functions, because you might have had proteinuria the month before and the month after, but not in this month. And it might actually have a half-life considered sufficient, so that if you bridge it from both sides over time, you will conclude that you have sufficient evidence for proteinuria also in February. Finally, if you have no data about the patient and the physician doesn't have any way to find out either, I would recommend to not use the guideline. And by the way, our quality assessment software would say, you have treated the patient according to this guideline without appropriate evidence.
So, because we ran out of time, I would invite anyone who has other questions or wants to read and our guest do this offline. So thank you all for coming.